Hello, thank you so much for joining our webinar on visual field billing and coding. My name is Rachel Krug, and I'm the CEO of Virtual Field. Virtual Field is an exceptional eye exam experience with visual field, color vision, and pupillometry exams in a portable, patient-friendly headset. And I am honored to be joined by Dr. Rumpakis today, who is going to briefly introduce himself and then walk us through his presentation. If at any point during the presentation you have questions, feel free to put them in the Q&A. I will be moderating the questions, and certainly we can answer any questions at the end of the presentation as well. Thanks so much for being here. I'm going to turn it over to Dr. John now.
Great, Rachel, thank you. I would like to say welcome to everybody, and thanks for taking time out of, I'm sure, what was a busy, crazy day as we get towards the end of the month to join us tonight. And I'd like to thank Rachel and her team for the privilege to be able to present this to you this evening. Before I get into the presentation, one of the things I want to stress about tonight is we can have a conversation. My goal is to make sure that when you leave tonight, that you have the ability to be able to go into your practices tomorrow and feel confident about how you code a visual field and what needs to be in the medical record, which of course is the most important part in delivering that exceptional patient experience and patient care. For those of you who don't know me, I'm celebrating my 40th year in the optometric field since graduating from optometry school back in 1984. And I've worn many hats in the field. I've been working with companies in the industry for quite a long time. The reimbursement consultant for the vast majority of companies in the eye care world. And it's a privilege and honor that I take very, very seriously, because as our scope of practice increases, our ability to see additional patients, provide additional care, do those things are really important, but it also means that we need to have a seat at the table with talking about how we apply utilization and privileges and being able to deliver this exceptional care to the patients out there. I've written for the journals for many, many years, a couple of decades, and having monthly columns. I own other companies in the eye care space, one of which we will use for demonstration purposes tonight, which is CodeSafe Plus, an online program, just to kind of demonstrate how you differentiate a CPT code and ICD-10 codes with respect to visual fields. Everything that I talk about tonight is going to be in real time as of today. Please make sure as you know, the rules differ by your zip code. And so please make sure you're familiar with the rules in your particular jurisdiction before you employ anything, just to protect yourself. And if you have questions directly about this lecture, here's my email address, or you can funnel them directly through Rachel as well, and she can get the questions to me. When you write to me, please just say, hey, I heard you on Rachel's webinar on Virtual Field, and here's where I live, and here's my question. So that way, when I answer the question, I can give you the best geographically specific answer for your question. So I want you to be able to, as I say, have a game plan on how you're going to implement the information we learn about this evening and discuss this evening. How are you going to implement it into your practice? And as I always say, a vision on doing things without execution is nothing more than a hallucination. I don't want you to just listen to what we're saying and say, oh, that was great. That was 30 minutes of my time. I want you to be able to have some takeaways tonight that you can apply into your practice right away. Having the right frame of mind is absolutely critical to be able to do that, right? So as you know, things change all the time. If you can forecast change or anticipate it, learn to embrace it and direct it. And that's when the true opportunity comes. As we're starting to see this tech cycle change, where we're now, moved from a big instrument in a dark room to a headset that I can, utilize anywhere in my practice, in the reception area, in another holding room in the back while they're dilating, whatever it may be. I'm saving time. I'm implementing new practice theorems that allow me to really become much more efficient, much more productive. And we're just at the very beginning of this, but as you start to see how you can apply the technology, that's really where the opportunity comes. I have to talk about the healthcare landscape briefly before we get into talking about special ophthalmic procedures and what needs to be in the medical record, and the coding specific to visual fields. So we have to go back to 2014 with the Affordable Care Act, because as you recognize, there's six pillars of the Affordable Care Act that are primary out there. There's some three big takeaways here as it applies really to eye care and where we are. The very first thing was cost shifting that the ACA did. It really shifted most of the costs back onto the patient. The average healthcare deductible today is approximately $6,700 per person. That means unless somebody has a catastrophic injury or something like that with their health, they are typically paying these costs out of pocket because these costs will be going to their deductible, which, as you know, they still have to satisfy before a healthcare insurer, or what I call payment assistance, actually can contribute to the patient's benefit. Individuals had to have coverage that was eliminated in 2018, and mandatory healthcare coverage by employers was never implemented. So really right now, the biggest thing that we are dealing with is the increased deductibles at the point of care in our practices. And as you know, healthcare is going up higher and higher. There's a lot of studies out here talking about individuals in different age groups, under 35 are deferring healthcare because of cost. Federal Reserve did a very interesting study. They said if there was an unexpected expense of $400, the average American would have to borrow or sell something in order to satisfy that. So I want you to kind of be conscious of this as you're delivering this care, right? Because the healthcare system, mandates that the care has to be medically necessary, and we'll talk about that as you're delivering it. But you also have to be prepared that the patient, even though something is covered, is probably the one that's going to be paying the bill. In the eyes of the healthcare system, there's no such thing as the medical model of care. There's only the eye care model of eye care. That means, irrespective of the patient's coverage, right, you still are obligated to take care of the entire patient, not worrying about who's paying the bill on it ultimately. So our foundation for change, let's kind of talk about what's going on in the healthcare marketplace. So audits are increasing both for medical and refractive carriers. There's intense scrutiny on medical necessity for special ophthalmic testing. Exams are under attack for audit to make sure that we're meeting the requirements of doing the appropriate type of exam. Carriers are telling us how to practice, meaning how many tests in a given time period they'll actually contribute to from a cost basis. And automation is driving everything. So as I say, we're just in the very first wave of this change. I'm seeing so much coming out now with artificial intelligence that are helping to interpret test results and make our job so much more easy to do, where we can spend more time with the patient, helping them understand the findings rather than going through and actually capturing the findings themselves. So there's a lot of changes out there. The wonderful thing is that the basics of coding and compliance have stayed the same. So there's what I call the holy trinity here. There's coding, coverage, and reimbursement. And they're vastly different, but they work together to bring together the fabric of the healthcare experience for the patient. So coding is the only legal way that we actually have to describe the patient-physician encounter, right? Every CPT code has a specific definition, and that definition has to be met while you're performing that code in order to use that code. Coverage is what happens when a patient has insurance, or as I say, what I call payment assistance, because the coverage will tell us the patient is going to have payment assistance that's going to be able to apply to that encounter or to that test. And then the coverage will also set the parameters of, I guess you would say, utilization guidelines on how many in a given time period a carrier or insurance carrier will allow us to be able to do. Then, of course, reimbursement is what we've agreed to be paid by contract from a payment assistance program, such as insurance. So again, coding, how we describe what we do. Coverage is how carriers set policies to pay and how much they'll pay. And reimbursement is, again, our contracted rate of reimbursement. I bring these up because all of these things come under the umbrella of legally required compliance. And why do we have to pay attention to all three? Because all three are required by law. If you recall, back in 1995, we passed a small law called HIPAA. And HIPAA says that you, as a licensed physician, must follow the rules of the CPT as developed by the American Medical Association, and you must follow the rules of the ICD, in this case, ICD 10, which is developed by the World Health Organization. So this is a legal responsibility to code. It's not a business building type of a situation. It's not something that I'm doing to make more money. We're talking about how to translate the excellent care that you're providing to your patients in an appropriate fashion and create a medical record to support that. So people ask me all the time, well, do I have to follow the rules and why? I'm an optometrist. People don't really pay attention to what we do. Don't fool yourself. Optometrists provide 77% of all first-time eye care encounters in the United States and 66% of all enduring care, according to the AOA. So we are highly visible. And two of the top 10 CPT codes that are used by in Medicare's ranking system are eye care codes. So we're not as invisible as you may think. The beautiful thing about the United States healthcare system, though, is that they allow physicians to get paid 100% of the time for 100% of what we do. That's a pretty amazing statistic, right? So here's how I would interpret that. And if you're working with your biller, go to them and ask them, hey, are we writing anything off to zero? If you're writing any special ophthalmic tests or any office visits, things like that, down to zero, that means somebody in your office, somebody on your team did not do their job properly. Because if you follow the rules the way they're laid out, you can get paid 100% of the time for 100% of what you do. May not get paid 100% of what you charge, but you'll always get paid and never have to write that off. So when it comes to coding, I always say take care of the patient and the code will take care of itself. The patient's condition determines everything that you do. What you do then is written down in the record. And once you've written things into the record, then you go through and you translate those actions into the CPT codes that most closely represent the services that you provided. Here's a big takeaway that I think you can apply to just about anything in your practice. What you have to do is stop making clinical decisions based upon the patient's coverage. All right. When Mrs. Smith comes into your office, Mrs. Smith may have myopia, presbyopia, and astigmatism. She also may have dry eye and she may have some macular changes. Your job is to take care of Mrs. Smith. It's not your job to worry, oh, she came in with a VSP form and her IMED form or whatever. Your job is to go to Mrs. Smith and say, Mrs. Smith, you have myopia, astigmatism, presbyopia. I also detected some initial signs of dry eye and you have some macular changes. Here's what we're going to do to treat your refractive problems. We're going to prescribe glasses and or contact lenses. I'm going to have you come back for a dry eye workup, and we're going to do some special testing, maybe with photos and a visual field to determine the extent of your macular changes. That's your job. Your job is to detect, diagnose, and treat. Then apply the payment assistance or the coverage that the patient has, and then figure out, again, where the patient pays and where the carrier pays. But you will get paid 100% of the time for 100% of what you do. The most important thing that you can always ask a patient is, why do you need to see the doctor, right? That's the most important question on each and every encounter, because a patient encounter should be very smoothly, depending on how they present to the office, whether it's online or by calling on the phone. The staff is going to triage them. They're going to determine resources that are necessary, meaning time, facilities, people, and space. And then the doctor has the easiest job of all. What type of exam do I perform? What level of exam do I perform? And then most importantly, into respect to what we're discussing tonight, what tests am I going to order? Right? And how do they get ordered? Now, the medical record is very, very important because it's the only thing that you can use to defend yourself in an audit. And it's the only thing that an insurance carrier can use against you in an audit. So if you know that, and you know that you're the one creating the record, that means that you can create a record that is absolutely audit proof, right? It'll withstand the scrutiny of an audit. What we have to, worry about is things of doing fraudulent nature and that kind of stuff. So fraud is and an intentional act, right? Fraud, you have to know what you're doing is wrong. You have to have deliberate ignorance of following the rules or reckless disregard of the rules. Most of the time, that's not what happens. Most of the time in eye care, in my experience over the last 40 years, most people just don't know the rules, and so they're not following them appropriately. Each and every time that you submit a claim, whether it's electronically or on paper, you are attesting that the medical record is accurate, it's complete, it shows justification of medical necessity. And if you've ever read the back of your CMS 1500 form, you understand that it's a contract, that it says right on here, all information is true, accurate, and complete. I know the rules. You can come into my office and I can show you the medical record. It'll substantiate everything that I did, right? And it complies with all insurance carrier program instructions or rules. Additionally, anytime you sign it, well, whether again in person or electronically, you're agreeing to be prosecuted ahead of time if you've submitted any falsehoods. So we want to make sure that you're doing it correctly and submitting it properly. The Office of Inspector General is the police force for Medicare, right? It follows the Medicare system. You also have to make sure that you're following what your other insurance carriers are telling you as well, because that's really important. So you have to understand what the environment is. Technology is aiding them quite a bit, right? It's very easy to look at a glaucoma patient and then say, I've got an H40.1132, primary open angle glaucoma, moderate severity bilateral, and I can now understand exactly what, diagnoses and CPT codes are aligning to that. And it's easy for me to pick out fraudulent claims or outliers if I'm an insurance carrier. There's all sorts of information out there, public domains, the Department of Defense, things like that, where you can really take a look at these things overall. So these things do happen. And if you think that they don't, then I think you need to do some more homework, right? So what I see in my experience, the top three issues for audit failure, again, special ophthalmic testing and not establishing medical necessity appropriately, right? So here's what we're going to cover tonight, right? We're going to talk about the top three in my 5 pillars of compliance. We're not going to be dealing with surgical procedures, and I'm not going to be dealing with clinical lab point of care testing. So I want to talk about the CPT codes first, right? Because every CPT code, there's certain characteristics that they have, right? And understanding these differences are integral to your ability to practice effectively and translate the care that you're providing to a third party outside of your office. So there's 3 levels of healthcare procedural codes, right? Level 1 HCPCS codes are synonymous with CPT codes. Level 2 are non-CPT codes that we typically use for routine eye care materials, services, and quality reporting. And then, of course, level 3 or category 3 HCPCS codes are used for emerging technology and temporary use codes. A CPT code, you always know it because it's always 5 numbers. So if we're talking with respect to visual fields, it's like 92081, 92082, 92083, always 5 numbers. A level 2 HCPCS code always starts with a letter somewhere in the range of between A through V, followed by 4 numbers. And a category 3 code is always 4 numbers, followed by the letter T. Just a quick note to help you in other aspects of your practice. Any time you see a category 3 code that describes a process that you're doing, please make sure that you collect from the patient, because the vast majority of category 3 codes are not enjoying coverage by any insurance carrier because they're deemed to be temporary use or emerging technology. Now, when it comes to what you should charge, obviously nobody can tell you what to charge, particularly in a public forum like this. But if you understand the basics of reimbursements, right? Reimbursements, we follow the resource-based relative value system that was developed in 1995. As you know, every single CPT code has 3 different factors with it: the amount of work, the practice expense, and the malpractice risks with it. And when I combine this with where you practice, that's what helped us determine the maximum allowable reimbursement. So just as a practice tip for you, you would always want to make sure that your usual and customary charge is always significantly higher than your highest maximum allowable reimbursement from any of your third-party carriers that you're doing. That's just prudent business. So I'm not going to tell you where to set that, but you should be higher than that, so you can always capture your maximum allowable that you are entitled to. Now, with respect to the chief complaint, as you understand, the chief complaint is very, very specific. In order for you to have any of your services or testing covered by Medicare, it's dependent upon the purpose of the examination, right? Not on your ultimate diagnosis. So if a patient walks in and they say, I have nothing wrong, I'm just here for a general eye exam, and you discover that they've got macular degeneration, that visit is not billable to a medical carrier because the patient didn't have a complaint or symptoms of an eye disease or injury. In fact, if the patient comes in with no specific complaints and you discover a pathological condition, that examination service is not covered. Furthermore, if you don't indicate your order correctly for a special ophthalmic test, one could conceivably also see that you're not establishing medical necessity for a particular test, and that test could be denied. So if we're going to meet the chief complaint requirement for an office visit, there's two ways, right? The patient directs it, they contact your office and they say, hey, I need to be seen, my eye is broken. Or you're bringing the patient back at a particular interval for a specific purpose and a specific test. So that'll come up in just a moment. As this little cartoon says, I want to run a few tests on you just to cover my you-know-what. Here's the deal. We cannot do prospective testing just to cast out a wide net to see what we can do and bill it to a third-party carrier. You have to have a specific purpose. The test cannot be confirmatory in nature. You have to be able to have a specific problem, a sign or symptom that you're seeing, and then you would order that test to help you either diagnose, follow a diagnosis, treat, or follow treatment of a particular condition. So when we talk about the concept of medical necessity, I hate to break it down like this because it sounds so elementary, but if we go to the dictionary, it means that what you're doing is absolutely required or indispensable, right? In other words, you could not properly manage this patient unless you had this test done, right? So if you already know the diagnosis and you already know the state of care, and it's that doing an additional test isn't going to change your management of that patient, then that test would be deemed as confirmatory or redundant and then is absent of medical necessity and wouldn't be properly covered in doing things. So you have to be very, very careful about this. So in the language of medical records, necessity means it's required or indispensable to do. If I look at Medicare's actual definition, Medicare says that these supplies or services that need to be proper and needed for the diagnosis or treatment of the medical condition, it's very important that you follow your local standards and are not mainly for the convenience of the patient or the physician. Here's what I say. If you feel, in your expert opinion, that a test is absolutely required to do to help you diagnose or treat a patient, then please indicate in the medical record what you want to do, why you want to do it, and when it needs to be done. I'd like you to come back in 1 week, Mrs. Smith, or 3 months to do a visual field secondary to the change that I'm noting today in your optic nerve. Okay, something explicit like that needs to be written into the medical record because it's very, very important, since that's one of the number one things that triggers an audit. So your take-home message on that is always include in your written order, in your EHR, include what you want the patient to do, what test are you ordering, why are you ordering it, and when does it need to be done? What's the interval of care that needs to be done with those tests? Now, when it comes to medical carriers and medical necessity, medical carriers will establish that for you through two different methods. One is national coverage decisions that come through from CMS that apply across the entire country, or CMS will also have what we call a local coverage determination. So what I'm going to do is I'm just going to jump over here to a different program, so that way I can kind of show you what that actually looks like. So this is my software program that I have out there in the marketplace. It's called CodeSafe Plus. I'm going to type in the code for visual fields, right? Threshold visual fields, and I'm going to click on this. And again, this is going to bring up a specific policy or an LCD specific to visual field testing, right? This was just established on October 3rd, 2024. So this is a very recent policy. These update weekly, just so you know. That's how frequently they change. And so I'm bringing up the actual LCD here. So when I'm looking at this, I can actually go ahead and go down to the indications for doing a visual field. So these are the rules and the regulations and the limitations of doing a visual field, okay, in this particular jurisdiction. So when I look at medical necessity and how it has to be explained in the record, the third-party carriers will oftentimes do that for you automatically, okay? So you have to be very cognizant of that. If the carrier doesn't have a policy at all, then it's your medical judgment following the explicit definition of the CPT code and your establishing medical necessity for that particular patient. If the patient is paying, they say, look, I know I don't have a problem, but my mom has a history of macular degeneration or a history of glaucoma, and I want you to do a visual field on me, then that's fine. You simply need to explain to them, Mrs. Smith, this is not medically necessary. We will not be submitting it to your insurance carrier, and you will be paying us our usual and customary fee out of pocket for this particular test. So if a carrier is not involved at all, you still have to code the encounter properly. You still have to code the test, but you're writing a statement in there that you've explained to the patient that this is not medically necessary, that the test is requested by the patient, and the patient is paying your usual and customary fee. So when we come into special ophthalmic testing overall, there's a number of different questions that always come up. So I'm going to just try to handle these all on one slide. You can do special ophthalmic tests on the same day as any exam services that you do. A patient can come in and they can have VSP or IMED. You bill the exam to VSP or IMED, and that you want to order a visual field, you can order and perform that visual field on that same day, and you would just bill the medical carrier for that particular test. So you're fulfilling two different contracts on that same day. You may have to collect two copays, depends on the insurance contract and what it says. Most typically, copays go with office visits and deductibles go with special ophthalmic testing. Visual fields does not require the doctor to be in the exam lane or in the office while they're being performed. They come under the rule of general supervision. That just means that the doctor needs to be available by phone. So it's important for you to realize that there are parameters that you can follow, and you can order visual fields ahead of time. So if you wanted to write in your record, order visual field Q 6 months and have that patient scheduled, and then that visual field test can be done at that 6-month interval based upon your order written into the record before that. The other types of things that happen with visual fields specifically, right? It has specific CPT codes, specific definitions. Again, you have to make sure you're following the given rules with that. The different definitions are by CPT. So when people are saying, well, I've got an instrument, I want to do a visual field, I'm not sure which one I'm going to do, make sure that your device and your order for that particular level of field is what's medically medically required. Do I need to do more of a tangent screen, auto plot, single stimulus level? Do I need to do something with at least 2 isopters, or do I need to go to a full threshold visual field where I've got at least 3 isopters, done? So again, it's up to you, doctor, to determine which level of a visual field is most clinically appropriate for that patient based upon what you're either suspecting as a diagnosis or what you've already diagnosed overall. Remember, visual fields, just like any test, is broken down into 2 different components, the technical component and the professional component. When you're doing that, remember that the professional component is your interpretation and your report. The technical component, it represents the equipment and the technician performing the test. That's why you can't bill for staff time and the test at the same time, because that would be a redundant or a double billing of that overall. So again, remember, you have to make sure you're following the rules of doing things. If you're doing, a visual field as an ordered test, you're writing down exactly what level of visual field you want, the reason why you're doing it, and when it's going to be done. If you're doing it as a screening test, it's generally not billable to a third-party carrier because you don't have medical necessity established for the record. You also have to follow CCI edits, meaning what tests can you do or can you not do on the same day as a visual field. And fortunately, visual fields are pretty forgiving. There's not, you can really do those on days, if I'm doing a glaucoma workup, for example, on a patient, I want to do a visual field and fundus photography and OCT of the retina and OCT of the optic nerve, for example. You can see that it's very easy to do things. Visual fields are allowed with everything, so you don't really have any conflict. You have more conflicts with things like photos and OCTs and things like that, but visual fields, you're real clear on the CCI edits in most cases. Again, if you need to do a visual field more frequently than a third-party carrier allows you to do, then you may need to use an ABN form, right? An ABN form is something that allows you to tell the patient in advance that this test may be denied for a specific reason, and they can still elect to do the test and assume financial responsibility for it. This goes back to you get paid 100% of the time for 100% of what you do. So filling out an ABN is very, very important. Using the correct modifier, 99% of the time it's going to be modifier GA. So you would file your claim as 92083-GA. The GA tells the carrier that you've done your job, that you've got a signed ABN on file, and then they legally and properly transfer the financial responsibility to the patient should the carrier deny coverage for something. Again, your interpretation and report is absolutely critical. Remember, especially with visual fields, if you're doing sequential visual fields, you have to have a statement of comparison to where it was before. And are things stable or are they progressing? Does this change your clinical management of the patient? Meaning, is it going to allow you to change their medication? Are you recommending surgery? Are you referring to a subspecialist? The interpretation and report, if it's not completed in the medical record, then the whole test is denied because you did not complete the professional component of that test overall. So the key is that if you really are protecting your medical record, right, creating it properly, indicating your medical necessity to do things based upon your clinical expertise, clearly writing out your order, doing your interpretation and report, that's what's going to allow you to benefit not only economically, but you're going to keep the money that you're getting because you're protecting yourself on audit. So as we kind of wind things up for our 30 minutes, my 12-step program kind of talks about making sure you understand that everything that you're doing is a business decision in addition to clinical excellence, right? So identify carriers who you want to work with, establish your needs for proper coding. If you don't have documentation or software like mine, you should think about that. Create your disease protocols so your staff can understand and explain to your patients what they're doing. Everybody has to be educated. Make sure you tell your patients that you provide this high level of advanced care, especially when you're doing cool new technology like the virtual field that, it's a headset that really gets patients going and thinking that you're on cutting edge. Never go below the standard of care as your baseline. Make sure you document your medical record just like you would a storybook, right? You're telling a story, so make sure your thoughts and impressions are in there. Make sure you're vigilant about coding properly and communicating change within the office, right? If the rules change on a weekly basis and reimbursements change on a quarterly basis, make sure that you stay up with those so that way your practice can benefit from following the current rules and making sure that you're getting paid the maximum allowable that you are due. So with that, again, we talked about the top pillars overall. I enjoyed the time and I'll be happy to open things up for questions.
Thank you so much, Dr. John. That was really informative. We do have a couple of questions from the audience. The first is, how do you go about which insurance, medical versus vision, to bill if a patient comes in for a routine exam for glasses, but you end up finding, for instance, mild macular degeneration that is not affecting visual acuity?
Okay, so the patient would be coming in and they would be underneath the auspices of their managed vision care. right? So you're not doing a routine exam, just to be clear, you're doing a comprehensive ophthalmological evaluation in probably 99% of the cases. So you're doing a 920X4, right? Either 92004, 92014 comprehensive exam. You're also performing a refraction. Included in your comprehensive exam is some form of confrontation fields or a screening visual field. So that's part and parcel of your comprehensive exam. If you determine that the patient has some macular changes going on during the course of that exam, then you would be making a preliminary diagnosis of what they have. You would want to then order a visual field. So if you're doing this all on the same day, this is how the billing would look. You would bill the managed vision care carrier, your 920X4, your 92015. You would then bill your 92081, 82, or 83, whichever you ordered. You would be billing that to the medical carrier. So you would have two different billings going out for that particular patient on that same day.
Thank you for answering that. The next question is, what about OCT for a glaucoma suspect? Is that a confirmatory test?
Well, it depends on what purpose you're doing an OCT. If you know that if you're suspecting changes or you're getting baseline for a patient, if you suspect that the patient is a glaucoma suspect and they meet the Academy of Ophthalmology and the AOA clinical practice guidelines for a glaucoma suspect, either high risk or low risk, then it would be identified at what testing you should be doing. Certainly, in a high risk patient, you're going to want to do a baseline OCT so you can evaluate exactly where that patient's nerve structure is at that point in time. If you already know that they have the disease and you already know that things are stable from other tests that you may be doing, then an OCT may be just redundant in doing it. Or if you're doing OCT with a frequency that exceeds what the clinical practice guidelines would stipulate. Typically, in a mild glaucoma patient, you're looking at two OCTs per year. In a moderate glaucoma patient, two OCTs per year, but you're alternating those with visual fields. And in an advanced glaucoma patient, no OCTs because visual fields becomes a predominant test for clinical evaluation at that point in time, and OCTs fall off the map.
Great, thank you. That is all of the questions from our audience. Dr. John, thank you so much for your time. This was amazing. Do you mind sharing your email one more time in case questions come up after this webinar?
Yeah, my email is right there. It's John, John, at prmi.com. And again, thanks to Rachel and her team for having me. Please identify that this was the lecture that you attended. So again, I know what lecture you're referencing, and tell me where you practice so I can make sure I give you a correct answer based upon your geography. So thank you so much. I really appreciate you all taking the your time out of your busy evening and joining me.
Thanks, everybody. We'll see you next time.